Hello and welcome to Invitation to a Conversation. I'm Pamela Bailey. My guest today is Dr. Collette Lee Lewis. Hi, Miss Dr. Lewis. How you doing today?
Hi, Pamela. I'm doing well. Thank you for asking.
Yes. My conversations where I want to go in the near future this year is to get more into social issues and the everyday needs and lives of people that I really don't have conversations with on my show. And so today I would like to get into kidney health because there's a large population in Brunswick that deals with kidney lifestyle, have a kidney lifestyle and deal with kidney issues. And so, my first question to you, Dr. Lewis, are you a native of Brunswick, Georgia?
Well, I will say not a native, but I feel like I'm a native. This is the the place that I've lived the longest in the United States since I've been here since 1989, essentially. So I've been here in Brunswick since about 2004. So I feel like I belong, but originally I was born in the Caribbean in a tiny British colony on a tiny island called Montserrat. It's one of the few remaining British colonies in the Caribbean. And actually, I was there until age 18. I did my formal education, my formal primary education, secondary education, and then I came to college when I was 18 in the United States.
Okay, I did a little history on your island where you were born from, and they were part of the Hurricane Hugo.
Yes,
So,
actually, when I left, yes, we got really devastated by Hurricane Hugo, really devastated. And we were able to recover from that. And then several years later, in 1995, we had a volcano erupt on the island, Sufria. And that has changed the landscape of the country. It has changed not only the landscape, but it made a lot of people, residents of the island, have to leave. So the capital, which was in the southern third of the island, was essentially destroyed from the volcano, and so most people have had to go to the northern third of the island to live, with the central area being considered unsafe. So yes, the population, which was probably about maybe 14,000, shrunk down to probably about 4 to 5,000
okay.
residents.
Well, I'm glad to see that you're over here and you're thriving and doing well. Since you've been in the United States, what are some of the similarities or differences in cultures of you growing up on a Caribbean island and living in the United States?
Oh, some of the similarities. Okay, well, I mean, actually, even though we're in the Caribbean, we have adopted a lot of Western culture. So there isn't a whole lot different in a lot of things that we do. Now, in terms of some of the native things some of the stories we grew up with, some of the cultural traditions we have, those are different. And there are times, especially in the Christmas season, when we have a little carnival times, or when we have calypso competitions, we have beauty queen competitions, we have a lot of cultural things that occur there. So that makes it different, and especially because we have the Irish settlers were reportedly the first settlers of the island, before, I guess, after the Caribs and Araks, which were the kind of the native people. So we have a lot of Irish names. So a lot of the people that you will find, they have Irish names. They are Ogaros, they are Irishes, they are Molly. Lots of the places in the island. We have St. Patrick's, so we celebrate St. Patrick's Day. So actually, on Friday there was a big celebration back home. A lot of people come back home just to celebrate St. Patrick's Day. There was a village of St. Patrick's. Unfortunately, that village got destroyed with with the volcano, but the spirit lives on, and people still come together and celebrate and have a good time.
Well, that's interesting. How did you find out about Brunswick, Georgia, and how did you get to come here to live?
That's a very good question. Very good question. Well, I mean, I had been in the States. I mean, I started off in college in Virginia. I was in Norfolk, Virginia. Then after that, I ended up, going back home for a short while and then coming back to school in Philadelphia. But in my after my training, I somehow met a doctor. My first job was in Lake Charles, Louisiana, and while there, I went to a conference, and I happened to meet Dr. Tucker, who was a local nephrologist who had a practice here. And at the time, he was alone and he was looking for help, or he was not quite alone, but he may have had one other partner, and then was looking for help. He wanted to expand the practice, have more practitioners, and he mentioned it to me. And but at that point, I had gotten the other job, and I was in my other job, and I thought maybe I would stay there, so I did not commit to that. But then I saw that I needed to kind of move on from where I was in Lake Charles, Louisiana, and so I contacted him, and he was still looking for someone, and essentially I reached out to him, and he was still looking, and he invited me. And I tell you, I when I came here, I was sold. I just loved the place. I loved the location. I loved the coast. Um, I loved the beautiful oak trees. It was so green. It reminded me of home in terms of the greenery. People seemed friendly. So I was just like, you know what? I think I can probably work here, and let's see how long this will work. And I've been here, and I've been here now almost 19 years. I mean, it's amazing.
You must have came in the spring or summer when everything was in bloom.
Yes, it was in the spring. It was actually in the spring, and it was beautiful. So yes,
Okay.
yes.
You have a very extensive medical education. You attended Old Dominion in
Yes.
Virginia, Drexel
Mhm.
University in my hometown of Philadelphia, the
Oh,
University of
you're
Alabama,
really
the
good.
University of Texas. In all, how many years of medical school did you attend?
Okay, so after I did my college in about 3 years, because I had some advanced placement credits that I brought from home. And then I went to med school for 4 years. And after that, I had to do my residency in internal medicine. And internal medicine was a 3 year program. So I did all 3 years at University of Alabama, Birmingham, at Birmingham, in their internal medicine residency program, which is an excellent program. And then I moved on to University of Texas, Houston Health Science Center, and I did 2 years of nephrology there.
Can
So that was about 12 years.
was 12 years. Okay. Was medicine your first career choice?
I want to tell you, it was my only career choice.
Okay.
I always knew. I don't know. It's kind of strange. People always ask me, "Did you always know you wanted to do medicine?" And I always say a resounding yes. I always wanted to do medicine. As most children, you want to do this, that, the other, and it kind of fluctuates over time. From the time I could probably speak, maybe three or four, I always said a doctor, and I never wavered. And so I had a laser sharp focus about becoming a physician, and um, I just would not. I couldn't see myself doing anything else, nothing else. And
Okay.
there were some reasons for that, I think. My grandmother, she lived in the United States. She was a citizen then, in the 70s. And in 1976, she had a stroke. She was a CNA. She was a certified nursing assistant then. And she had a stroke that incapacitated her and made her disabled where she couldn't work. So she then
Mm,
came to live with us. So that kind of solidified my desire to become a physician. I mean, she was not paralyzed in any way, but she just couldn't work that job anymore. And she was a diabetic. And those things kind of just made me get more curious about medicine. And I will tell you, she's one of the driving forces why I became a physician.
Very good. You have education in internal medicine. Can you give us an explanation, a short, brief synopsis of what that study is? What is that study is?
So internal medicine is really adult med. It's a medicine for adults. So essentially, you're taking care of an adult. An adult has all the different systems: the neurological system, their heart, their lungs, their GI tract. So you do a little bit of everything. You're not a specialist, but you take care of the general stuff that concerns an adult. And then when you want a little bit um, more specialized care, then you will refer the patient to a specialist. So as an internist, you can do primary care
Mm.
practice. That's what I've done. I've done that, and I'm doing that.
You are you are answering some very good questions that I've been curious about. Thank you. And
Mhm.
you have education in cancer. Is it in various cancers or a particular
No.
type of
Now,
cancer?
I think when you're talking about the cancer, I did work when I was in training at the University of Texas, Houston. We rotated through MD Anderson Cancer Center as well as Memorial Hermann Hospital. Now, we as the fellows for University of Texas, Houston, we provided the nephrology care that patients who were at MD Anderson Cancer Center, we provided their nephrology care. So we did the nephrology consultations in concert with our attendings. But I don't treat cancer. I don't specialize in that. It's just that
Mm.
I did that in that setting, which was I mean, everybody knows MD Anderson Cancer Center is one of the premier cancer institutions in the United States, and not only in the United States, in the world, because so many people come from overseas to MD Anderson Cancer Center for their treatment and care.
Okay. Now, your specialty is in nephrology. Can you explain to us what nephrology is and why you decided to study in that?
Okay, so nephrology is really now a subspecialty of medicine where we look at diseases that affect the kidney, um, that and even probably that relate to hypertension, because hypertension ties into the kidney, is related to the kidney in many ways. So we take care on the medical side of things that affect kidney function, that cause kidney damage. When we take care of patients who have chronic kidney disease, that means they have damage to the kidney. Patients who at the end maybe of progression of the chronic kidney disease end up on dialysis. We take care of those patients who are on dialysis. And then we take care of patients who, if they are fortunate enough to be transplanted and have a transplanted kidney, we take care of those patients as well. So we kind of take care of the spectrum from healthy kidneys, damaged kidneys, um, patients who have end stage renal disease where the kidneys have totally failed, and then those, if they're lucky enough to be transplanted again and to have pretty normal kidney function again, then we take care of those patients.
So is that the same thing as defining what chronic kidney disease is, or can you explain that separately?
Okay, so chronic kidney disease is defined as a change in the function of the kidney that lasts for more than 3 months. And that, if, when measured by specific lab tests or being followed by the nephrologist, that patient has a GFR, a glomerular filtration rate, or percentage of function that is less than 60% or 60 mils per minute. So it is anywhere where we're talking to taking care of a patient who has, or talking about a patient who has damage to the kidney where their GFR is less than 60 mils per minute for greater than 3 months. That is what we call chronic kidney disease. And of course, there are different stages of chronic kidney disease. There are actually
Hmm.
5 stages of chronic kidney disease.
Right, and we're going to get into that. What's the causes and symptoms of? Can you hear me? Can you hear me now? You can hear me? Can you hear me now? Can you hear me now? Can you hear me? Hmm.
Okay, now I'm here. Okay, can you hear me?
Yes.
Okay, now I can hear you. I
Okay.
don't know what happened.
Okay. Um, so what's the causes and symptoms of? Can we go forward by calling it CKD or chronic
Yes,
kidney
we can
disease?
say we can talk about CKD for short. Yes.
Right. What's the causes and symptoms of CKD, chronic kidney disease?
Well, there are many causes for chronic kidney disease. Um, the most common, the two most common that we know are diabetes, which causes about 50% of the cases of chronic kidney disease, and hypertension, which is probably the second leading cause and causes about 35% of those causes of the other cases of chronic kidney disease. Then there are other diseases that affect the meat of the kidney, and those can be glomerular diseases, and then there are also diseases that can cause cysts in the kidney. And those types of diseases are probably the remaining 15% of the other causes of chronic kidney disease.
Is kidney disease generic?
When we use the term kidney disease, it is a generic term because it's kind of a catch-all term. But then that's why you go to a nephrologist to kind of help define and kind of figure out maybe what's caused the chronic kidney disease in that particular patient's case.
Okay. Can it be environmental? Because here in Glenn County, there is a large population of kidney patients. Is there, it could it be environmental lifestyles?
Um, well, I wouldn't say necessarily environmental. I would say related to lifestyle. There is a certain amount of, the way we eat. A lot of us are obese. We have diabetes, um, and high blood pressure. So I would say more, maybe the causes are diabetes, high blood pressure, lifestyle related, we eat, dietary changes, dietary reasons causing obesity, um, that relate to why we have such a high population of chronic kidney disease locally.
Ne-
Actually, the Centers for Medicare Services, CMS, they keep up with the numbers. And as of 2019, anybody who has Medicare, they kind of follow the diagnosis that they have. In 2019, they decided that they looked at the numbers, and about 24 patients out of every 100 had, in Glenn County, had the diagnosis of diabetes. And
Wow.
19 out of every 100 had the diagnosis of high blood pressure. So that is a very highly prevalent, uh, those are very highly prevalent diseases. And that's the reason why we're seeing so much problems with chronic kidney disease in our area. And
Right.
then we haven't even talked about obesity, because if you talk about obesity and TMIs that are greater than 30, you know that there is definitely a problem.
Right. Is these numbers deal with gender, age, and race?
Well, definitely there is a predilection for chronic kidney disease in the African American or Black community. Even though we make up only about 13% of the population, we have about 35% of the cases of chronic kidney disease in the nation, which is amazing. Actually, overall, in the United States, 1 in 7 persons has chronic kidney disease. So 13% in the nation, we are 13%, and we as Blacks are 13% of the population, but we have 35% disease. We are four times more likely than our white counterpart to have chronic kidney disease.
Wow. Is there an age? What's the youngest age that CKD can be detected?
Well, I'm not a pediatric nephrologist, so I don't really know the numbers, but I do know that, I mean, these days, obesity is a problem. We're having more diabetes, younger people, diabetics. You're finding young people who have high blood pressure. Because if you have any of those diseases, then you have risk factor for chronic kidney disease. So I'm sure that you probably can't find teenagers who may have damage to the kidneys, uncontrolled diabetes, high blood pressure that may not have come to notice, or those are things that are probably.
So let me ask you that. So what is the connection between diabetes and hypertension that causes CKD?
Well, the problem with diabetes, and I think we might need to think of them individually as causing issues, but then when you have both diseases together, then you have a double whammy. So diabetes can affect the kidney, especially uncontrolled diabetes. It affects the filters in the kidney. We think each kidney has a million filters. And if we think of the filter like a small, tiny strainer, you're filtering blood. And what comes up at the end is the liquid that makes urine. And what you're supposed to keep behind the strainer are proteins that should stay in the blood. But what happens with diabetes, uncontrolled diabetes, is that holes get made in the strainer that are bigger than those small protein particles. And eventually you have protein that goes through the strainer into the urine. That's what we see. And that's what we detect early. Let us know that there's chronic kidney disease or damage to the kidney.
Okay.
The same thing also happens with high blood pressure. You have pressures that are very high. You have pressures going through tiny blood vessels in the strainer. And with time, if the blood pressure isn't under control, same thing happens, and you have these holes made. The more pressure you have attached, the bigger the hole becomes, and the more protein is those things over time cause damage. And high blood pressure is what is called fibrosis or scarring in the kidney. And over time, that kidney shrinks. So that's how damage gets done.
What is the stages of CKD?
Okay. So there are 5 stages of kidney disease. Stage 1 essentially is pretty normal kidney function, greater than 90%. You have a GFR greater than 90 mils per minute. Stage 2, mild disease, and you have a GFR that's 51 to 89 millimeters per minute. Rough approximate 60 to 89%. Stage 3 is when you have moderate damage, and that's when we start talking about chronic kidney disease. And saying that this patient really has when they have a GFR less than 6, so anywhere from 30 to 59, anything less than 60, 30 to 59 mils per minute is stage 3. And in stage 4, we're from 50 to 29 mils per minute. So 15 to 29, that's severe disease, severe damage to the kidney, and that's stage 4. Stage 5 is less than 50 mils per minute, and what we call end-stage cirrhosis. And that's when we talk about kidney failure, and that's when we talk about eating dialysis. It's less than 50.
Can the kidney rebuild its can your body organs rebuild itself based on the stage that you're in with
Well,
CKD?
typically, depending upon the cause of why you have chronic kidney disease, a lot of times you cannot have improvement of the function. Diabetes is one of those diseases that once the damage is done, unless you try to get your sugars under control, you kind of have progressive damage being done to the kidneys. And so that in that stage and in that circumstance, most likely you won't have reversion of the function to normal. Also, with high blood pressure, the same is in effect, where you have damage done to the kidney. It's not necessarily progressive if you don't keep your blood pressures under control. The damage gets done, it's done. But once you keep your blood pressures good after that point, then it may stay at that level and not worsen. Now, if you take certain medicines that are harmful to the kidneys, medicines like Motrin, Advil, what we call the NSAIDs, the non-steroidal anti-inflammatory drugs like Motrin, Advil, ibuprofen, Aleve, naproxen, the goody powders, those medicines, if you take those for a short period of time and you may have damage, sometimes you might find that some of that damage gets better if you stop the offending agent. Sometimes if you're given like IV contrast, IV dye, it can damage the kidneys if you already have significant chronic kidney disease, but sometimes it can damage the kidneys and then your kidneys can get better in certain circumstances. So there's some circumstances where maybe your blood pressure got really low, you got really dehydrated, you had a little damage, but once you regain proper blood pressure levels and you got hydrated, your function returned to normal. But typically, a lot of times when the damage is done, it's done. So that's why it's important to protect the kidneys and know what those risk factors are so that you don't continue to perpetuate the damage for an extended period of time.
Mhm. Is having CKD a death sentence?
It's not a death sentence. Of course, we're talking about a chronic health issue. So when you talk about having something chronically, of course, it's frightening for most patients. And of course, if you're stage 4 and you're or touching stage 5, or if you're stage 5, you feel, oh my God, my life is at an end. And so many patients they get so overwhelmed with fear, and that is why education is key, because the more you know, the better you can do to help yourself and prepare yourself to be able to cope with a chronic health matter, because it is a chronic problem. It's a chronic disease, and you have this disease. It is not necessarily a death sentence. People live um, longer these days, even if they require dialysis. Say the kidneys have failed, they require dialysis. They can live longer if they do the right things. People who have chronic kidney disease, if they have stages 2, 3, 4, chronic kidney disease, there are medicines out there that potentially can help slow the progression to end stage renal disease, to requiring dialysis. So there are things that can be done to help patients these that we didn't have. And some of these things have only come up in the last year or two, and that can potentially help patients who have these issues. So it's not a death sentence. And then, God forbid, if you end up being on dialysis or headed towards dialysis, if you are able and a good candidate for transplantation, which that decision never is mine, we refer the patients to the transplant centers when their GFR is less than 20 milliliters per minute. So when they're less than 20%, the patient's referred to a tertiary transplant center, place like Mayo Clinic or Augusta University or Emory in Atlanta, or even MUSC, Medical University of South Carolina, or Piedmont in Atlanta. There are quite a few available in the area, and they're evaluated by the transplant team for what you would call the appropriateness of them being a transplant patient. There's certain criteria that they have to meet. They have to make sure that they don't have any other problems that could probably exclude them from being on transplant. They can't have had recent cancers, or they have to have a pretty good heart, have no significant lung problems. They just evaluate you completely first, and then they decide whether or not you're an appropriate candidate for transplantation.
Okay. The sound was messed up for a second there. Can you repeat the medicines that you said can cause? You mentioned Motrin, things not to take.
Okay, so the medicines that I suggested that you probably should avoid if you have chronic kidney disease are medicines that are called NSAIDs. They're a class of drugs. They are the anti-inflammatories. So a lot of people use them for pain and inflammation. So they are Motrin by brand name, Advil by brand name, both of those being ibuprofen, which is the generic. Um, there's Aleve, which is a brand name, or but or naproxen, or the generic naproxen should be avoided. And there's some things like nabumetone, meloxicam, or Mobic, or indomethacin. Those are all NSAIDs. Those should be avoided. And diclofenac, which is Voltaren. Those kinds of medicines should be avoided.
Didn't you say goody powder?
Goody powders as well. Absolutely. Goody powders.
Hmm.
Absolutely. Hmm.
Okay. Thank you. Now the treatment. What are the what? How many types of treatments are there with people with CKD?
So we don't necessarily say treatments. The what we should probably say
Hmm.
is what we try to do. If you're diabetic, one thing that you if you're diabetic, most patients who have chronic kidney disease, they're put on some specialized blood pressure medicines, either lisinopril, the ACE inhibitors, or ARBs, to help reduce protein and to kind of protect the kidney. Those are important. There are some other new drugs, Farxiga, and one or two others that also have been found to have some benefit to help with chronic kidney disease. Now, some patients are able to tolerate them, some patients aren't. So it's an individual decision between the patient and the doctor whether or not it's appropriate for that patient to be placed on that medicine at the time. Because sometimes there are some extenuating circumstances. Some medicines might cause higher potassiums, and you might not be able to take that medicine due to that. Some people have side effects from some of the medicines, cough. Some people have anaphylactic type reactions where the lip swells. So there are different reasons why some patients aren't on some of these on some of these medications. So that would be something that they would have to talk to their nephrologist about.
Okay. I have how you pronounce this perio dialysis is two types.
Peritoneal dialysis. Peritoneal
Yeah.
dialysis. Okay, so we're talking then about treatment modalities. So unfortunately, for if you have gone through stages 2, 3, 4, you're now at stage 5, end stage renal disease, what we call end stage renal disease, then there's several modalities for treatment. Typically, most people know about um, the in-center dialysis, blood dialysis called hemodialysis, where they go to a center 3 times a week for 3 to 4 hours each treatment, roughly, and they get their blood cleaned. Okay. There is also another form of dialysis. There's also home dialysis, which you can do either peritoneal dialysis or you can do home hemodialysis. Now, there are far fewer people doing home hemodialysis because you have to have maybe a companion helping you with the home hemodialysis. You have to be able to stick yourself and do those things to have access to your blood, and it's a lot more, for some people, more daunting to do home hemodialysis. But peritoneal dialysis is done where a tube is inserted into the abdomen, and we know that around in the abdomen. Of course, you have your intestines, and you have many feet of intestines, and those intestines have a rich blood supply. So we're bringing, by putting the tube into the stomach, we're putting it in the space that's around the intestines. And what is done is that fluid is put in through that tube. It's allowed to sit and is in contact with that rich blood supply that is all over the intestines, and it allows for diffusion, transfer of the waste from the blood into that solution. That solution that is pumped in is then drained, and that process is done maybe 4 or 5 times over an 8 hour period. And most patients, a lot of time, it's being done by a machine, and they're sleeping while it's done. This can also be done manually, where you hang the special fluids on a pole, and you might walk around with the fluid 3 or 4 hours during the day, but then you have to change the fluids out. It's a little more laborious that way, and there's some patients who do that for certain reasons, but most people like to do the machine, where the machine controls the fluid in and out. It's programmed to put the fluid in and out over that 8 hour period. And so many patients do that at home. Now, we would like to see more patients do who do home dialysis and do the peritoneal dialysis, because it's a gentler form of dialysis. But because some people, they may not have the space at home to be able to do it, because you have to be very meticulous. If you have animals, you can't have animals in the room that you're doing it. You have to be very clean. You have to have good body hygiene. Your environment has to be clean. So sometimes that can be problematic, especially if people are sharing space with others, etc. So um, we see fewer people choosing peritoneal dialysis, but it's an excellent way to do dialysis.
Mm, very good explanation. And you already talked about hypertension. How do you manage hypertension?
Well, typically those it's done by medication. Now, there's some lifestyle changes. There are things that we can do to help with high blood pressure. Definitely, we want to restrict sodium in the diet, restrict salt. We usually suggest that you try to do a 2 gram sodium diet, restrict all sodium to 2,000 milligrams or 2 grams a day. Um, that's helpful. Also, weight loss. If you're obese, losing some weight, you'd be surprised to know what 10, 20 pounds of weight loss can do to someone's blood pressure. So if you're overweight, definitely you're encouraged to lose weight. And of course, then there are the medicines. There are different medications that we use, different medicines are for different reasons in a patient when we start these medicines. But it's important that no matter how many medicines we give, that medicines don't work if you don't take them. And you'd be surprised to know that there's so many patients who are given medicines, but they don't take them. And especially in our community, our men especially, because sometimes some of the medicines can cause some erectile dysfunction issues. Um, and of course, that part of their life is very important to the man. They don't take their medicines, and then unfortunately, they end up, because they're not taking their medicines either consistently or taking them at all, they end up with chronic kidney disease, kidney failure, end up on dialysis just because of lack of taking medicines.
Mm,
And that is very sad. Also, a lot of times we see people end up with devastating strokes because they did not take their blood pressure medicine. you know.
mm,
So, it's just always important to remind patients you must take your medicines. You must take your blood pressure medicines. And the medicines work. And when you see the blood pressures come down, don't stop taking them and think that you're all of a sudden healed
right,
and everything's good. The medicines,
right.
your blood pressures are down because you're taking your medicine. When you stop taking your medicines, your blood pressures are going to rebound and be just as high and be just as dangerous. So,
Mm-hmm.
just have to remind people of that.
Mm-hmm. Very good. If someone is on dialysis, can they ever recover from being on dialysis, or will they always be on dialysis?
No, it depends upon what caused them to go on there. Now, if you have something progressive like diabetes, where we talked about diabetes being progressive, the damage is done and it just slowly worsens over time.
Mm-hmm.
a lot of times those patients don't recover. Or if you've had high blood pressure and you've had it poorly controlled, the damage, you have had significant damage, and you've not really taken care of yourself, there's a potential for it to worsen. Okay. Now there's some instances where someone might have been on a medicine that hurt them temporarily, and they're requiring dialysis for a short while, and they're able to get back off dialysis. Or if they were given some other nephrotoxic agent, whether maybe IV contrast, maybe for a CAT scan, and it caused some acute kidney injury, and they didn't have underlying kidney issues, there's a good possibility that they might get better. Or if they had some awful infection and they were septic and had septic shock and the kidneys were in a state of shock, it might take them some time to recover from that. And over time, as the tubules regenerated, you might see some improvement in the kidney function. So
Mm,
there are times when that does happen, but a lot of times when patients go to dialysis, it is unfortunately for most the end of the road.
mm, mm. Can a person live with one kidney?
Absolutely. If that one kidney is healthy, I mentioned earlier that each kidney has 1 million nephrons. Um, if one of those kidneys, say, there are people sometimes who are only born with one kidney, or if they had to have a kidney removed, say, for maybe reasons where it was either injured, or they had chronic infections, or it was full of stones, or they had kidney cancer and that one kidney was removed, and they had pretty good function in the other, they could live just as well with one kidney.
Mm,
So we see people who have that, and there's some people who never even had a kid. They were only born with one, and
mm,
they've lived with that one kidney. Now that one kidney is doing the work for two, so it may be overworking. So that's why in those patients, especially, they want to keep their blood pressures good. If they have high blood pressure, they want to. If they're diabetic, they really want to keep those blood sugars controlled, because you have that one kidney doing all the work. And then if you're adding any other insults to that kidney, that's not going to be good.
mm. So let me ask you this. So anybody who has CKD, is that normally both kidneys are affected, or can it just be
Yes,
one?
yes, yes. Typically, when you have chronic kidney disease and you have it from diseases like diabetes or high blood pressure or HIV or IgA nephropathy or some other form of glomerular disease, both kidneys are affected. The meat of both kidneys are affected.
Okay.
Mhm.
Um, what is life after a kidney transplant?
Okay, so a patient gets transplanted. It's usually a joyous time. Most of the time, the kidneys will just work just wonderfully well. And there's sometimes where some people, it takes the kidney a little while to wake up, and to actually work correctly. Now, granted that they're probably no longer requiring dialysis, they are off dialysis. Now, you have a lot of medications that you have to take, okay? Because you are now having somebody else's organ in your body, and the natural um, the natural response to our immune system is to fight anything that is foreign to our own bodies. Even though it's a kidney from somebody else, they're gonna it's not your own. It's the body's nature to try to fight it. So of course, patients are put on a lot of medications to try to keep their body from rejecting the kidney. These medicines are called immunosuppressants. Some of the names of these medicines, you might hear Prograf or tacrolimus or Cellcept or mycophenolate or prednisone, or a combination of the three medications. They may be on they may be on prednisone, they may be on Cellcept, they may be on tacrolimus or rapamycin or whatever form of medicine that they use as immunosuppressive therapy. Also, they also put, because in those very first weeks and months, they are extremely susceptible to other infections because they're so immunosuppressed. They may be put on antiviral medicines to prevent CMV, to prevent CMV, which is cytomegalovirus. They put on Bactrium to prevent something called PCP pneumocystis. Pneumocystis. So they are taking lots. So other than their immunosuppressants, they're taking an antiviral, they're taking an antibiotic, they're taking other medicines to kind of help protect them at least until their immune system is more attuned to the new kidney that is within them. But usually, most patients after several months, they feel good. Um, they're able to we just get back into life and into living. It's a big thing when you've come from dialysis. Maybe you've been on dialysis 3 hours, I mean, 3 days a week, 4 hours each time. And then after that, not having to go to dialysis, being off dialysis, they have all this new time and they're like, oh my God, what do I do? But usually, most of the times, they can find things to fill that time. So
Mm-hmm.
usually they do quite well. And it's so nice usually to see the patients thriving and doing well, resuming their lives. Some go back to work eventually if they were working before. It's just nice just to see them kind of living life again, feeling like they're living.
Yes. Is what do you have updates on the current research on CKD, and is there any medicines or anything for early detection to slow it down or advance it or get rid of it or to
Well,
do better
they
dialysis treatment?
okay, so I mean, there's always ongoing research in chronic kidney disease. Now, I'm going to tell you that I am not always attuned to everything that's happening out there because there's so much so there's a global, chronic kidney disease is a global problem, and there's so many studies that are being done in Europe, I mean, all over the world, for chronic kidney disease. There are recently new medicines, that diabetes medicines, that they've found helps with slowing progression of chronic kidney disease, decreasing protein in the urine. Those things are an added tools to the armamentarium that we have to treat chronic kidney disease. Um, there's so much ongoing research. There's always been research going and still is ongoing on an artificial kidney that would be wearable for patients, individual patients, so that they wouldn't have to necessarily go to dialysis to go to a unit, but that they could wear this constantly. So there are strides being made in that. Now, I'm not sure that it is past the research stage where people are actually using these on a daily basis.
Right.
Um, they're prototypes and people are constantly working on things. So, it's such a big field and there's so much being done in it.
So you talk about protein in the kidneys. Is it any way that us everyday people can tell if we have more protein than enough in our kidneys?
Okay, so we've talked a lot about chronic kidney disease. Let's talk about some of the signs of chronic kidney disease, some of the early signs and symptoms that
Right.
people might find if they have chronic kidney disease. Okay, so some people may have swelling, um, swelling of their legs, ankles. They may find themselves puffy eyes. Some have, some may be just fatigued, really fatigued, um, and that may come from anemia. They may have low blood count. Um, Others may have some back discomfort in the back. I get asked a lot of times, if I have a backache, is that my kidneys? It's not always your kidneys, and most of the times it's not. A lot of times it's musculoskeletal. Um, Other things that sometimes people experience and may see is that they have foamy urine. When you're spilling a lot of protein into the urine becomes foamy, like you have bubbles in the urine. When you pee, you see a lot of bubbles, like you almost have soap suds in the urine, in the toilet. So that's a sign that there might be protein spillage there. Other things that you might see if you have chronic kidney disease is maybe a sudden spike in blood pressures. Blood pressures start going high, um, and they become uncontrollable. You might not have even had a high blood pressure before. New onset hypertension could be a possibility. And not meaning that every time somebody develops hypertension, they have chronic kidney disease. That's not what I'm saying. But you might find
Right.
that your blood pressure had been relatively controlled, and then of course now all of a sudden it's spiked. It could be an early sign of chronic kidney disease because the kidney elicits certain hormones that can elevate the blood pressure.
Mm.
Okay, so those are some of the signs and symptoms of chronic kidney disease. But definitely, how we know for sure is when you go to your physician and they test you. They may do your blood test, and we check something called creatinine. Creatinine is a waste from muscle, and we expect a certain level of that creatinine to be in the blood. But when we see elevated levels of that creatinine, we know that there's something going on with the kidney because the kidney is the only organ that gets rid of that creatinine. So when we see the levels going up, that means that the kidneys aren't getting rid of it effectively. So that's a signal that something's going on in the kidney. Also, that creatinine is helped to that creatinine level is used in a formula along with age and race, um, to determine what your GFR is, the glomerular filtration rate or percentage of your kidney function. So that's a number that everybody needs to know. They need to know what their GFR is. The other thing is when you go to your doctor, they may ask for dipstick of your urine. Ask for a urine sample and it's dipsticked, and we're looking for protein. So if there's early signs of if you have a UACR, which is a urine albumin creatinine ratio that's greater than 30 mg per gram, that may suggest that you have some chronic kidney disease because then you're spilling you're spilling amounts of protein into the urine. So that's another number that you need to know. If you're diabetic, even if you're not diabetic, I think everybody should know what their hemoglobin A1C is, that A1C, to know whether you're pre-diabetic, to know whether you are diabetic, and if you are diabetic, what the level of your control is. The goal for your hemoglobin A1C should be less than 7 if you're diabetic. If you are not if you're not even pre-diabetic, your hemoglobin A1C should be 5.6 or less. Prediabetes is defined by a hemoglobin A1C of 5.7 to 6.4. 5.7 to 6.4. So definitely you want to be 5.6 or less so that you're not in that pre-diabetic space. And then if you are in that pre-diabetic space, discuss with your doctor how you can get out of prediabetes. One of the easiest things, diet. So you want to cut back on a lot of the starchy foods that you eat. Um, Eat more green and leafy vegetables. When you have a plate, maybe make half of your plate green and leafy vegetables, a quarter of your plate be your protein, your fish, your meat, your chicken, and then the other quarter be your starchy stuff. As Black people, we tend to eat big helpings of starchy stuff. You go to a dinner, you get a plate, and typically you'll have mac and cheese. You'll maybe have some rice, some green beans, your meat, and on top of that, you still have a roll. You have about 2 or 3 starches. I mean, it's true. Being honest. We're speaking honestly and candidly here.
Yes, yes.
So typically, what that should be look more like is your meat. You should have more greens, and then you have one helping of the starch. If it's going to be mac and cheese, just that. No additional roll with it. No, if you mac and cheese, no rice with it. If you're going to have rice, no roll or mac and cheese. So one starch,
Mm.
and then so that's if you can just cut the starches out. If you're a pre-diabetic, if you can exercise, bump up exercise. We all should be exercising, trying to go walking 30 minutes, 3 to 5 days a week. That helps if we can that will help with weight loss, that will help with metabolism, that will help with using up the sugars, and help with decreasing some of the insulin resistance that some of us have when we are obese. So those things will help kind of move us away from prediabetes. Now, so what are some of the risk factors? We've talked about chronic kidney disease, but what are some of the risk factors? So number one, if you're diabetic, that's a risk factor. If you have high blood pressure, that's a risk factor. If you're older, that's a risk factor. If you have a family history of chronic kidney disease, if you have a family member who has chronic kidney disease, that is a risk factor. If you smoke, smoking itself can affect the kidneys and cause problems, because when you smoke, you're causing vasoconstriction, you're causing those blood vessels to tighten up, and you have poorer blood flow to the kidneys. So that in itself also is a risk factor, for
Mm.
chronic kidney disease.
Boy, Dr. Lewis, I tell you, that was an in-depth conversation, and I appreciate you. And you did get into some of the recommendations for dietary. That was my next question. So, to kind of end this conversation, you not only see patients here in Brunswick, Georgia, you have five surrounding counties, which is
Right,
Liberty, Ware, Brantley, Wayne, and Appling. Do
right.
you do patients come from there, or do you go there?
Okay, so I have, it's a combination. I have patients who are referred to us, for chronic kidney disease evaluation management, um, uh, who come from those counties to us. We do have the practice that I'm in, Nephrology of the Golden Isles. We do have some satellite offices in Appling County, in Wayne County, in Liberty County, and in Camden County. But we also serve dialysis units and our patients that live in those counties. So I personally, I see patients in Ware County. I go to Waycross. I go to Baxley in Appling County. I go to Jessup, and of course see patients from those dry areas, from Liberty, etc. And here in Brunswick, I see patients from, McIntosh. I see patients from Brantley. I see patients from Camden counties. So we see patients from all over,
Mm.
essentially.
And so, I understand that one day in March it was International Women's Day. So I
Yeah.
salute you and held
Oh,
my hat to you for a
and that
job.
to you too.
Yes, thank you,
Yes,
thank
and
you.
to every woman who's listening to us. Yes.
Yes. And also to give you some more information about Dr. Lewis here. She is a member of the local chapter of the Links. She's a volunteer at MAP International, and she belongs to a nonprofit. She's a member of the Medical Association. She's on the American Society of Nephrology, and she's a double board certified in internal medicine and neuropathy. So, does that double board mean internal medicine and neuropathy together? That's
And nephrology. So,
nephrology.
yeah, so there, you to be okay. So, as an internist, we know nephrology is a subspecialty of internal medicine. It's just like cardiology is a subspecialty of internal medicine. So, I have my boards. I've sat for my boards in internal medicine, passed those, and then as to maintain my nephrology certification, I have to sit an exam and be certified, in that as well.
I was going to say that name wrong, didn't I? Nephrology.
Nephrology. It's nephrology. It's all right. Don't worry.
So,
Nephrology.
thank you, Dr. Lewis, for an in-depth conversation of the kidney. You did an excellent job of it explaining.
Mhm.
Um, to end this conversation, who inspires you?
That's an interesting question. Who inspires me?
Mm-hmm.
Well, I would say every day my patients do.
Mm,
Um, my
mm,
patients do. The
mm,
reason I do what I do is because of my patients. Um, I think of my, let's think I think back to my mother, who she's present with me, and I think back to my mother's mother, who I spoke about, who was sick, and to my even my father's mother, who was kind of who was a shut in her older ages. I think of the patients that I see every day, who look like me.
Mm.
Um, I think it's important for people of color to see physicians of color. It's
Yes,
important.
yes.
And that's why I encourage, and I encourage our young people to pursue medicine, pursue medicine, because we need to see somebody who looks like us. There's been so much distrust over the years of people, of other physicians, unfortunately, who are not of color, in our community. And I think that has been a big problem in why our patients, sometimes, or people don't come to see the doctor. Um, I think, there's lack of access. Some people don't have insurance, unfortunately. But then also there's a distrust. Even if they do have insurance, there's a distrust. The doctor may tell them do something they just don't trust. So it has helped. I mean, those are reasons why I do what I do. I mean, probably I could go somewhere else. I could go to another community. I've been asked to, I've been offered jobs elsewhere, bigger places, probably more money. I mean, seriously. But I've
Mm-hmm.
chosen to stay here because there is a problem here. We have a lot of chronic kidney disease. We have a lot of patients who need just good care. And
Mm.
so, I always have strived to do the best for my patients that I can. I was a patient myself. Even when I was training, I became a patient. I had a situation and I ended up being in the hospital and being a patient. And I tell you, I was in my training, I knew a lot, but when I became the patient, it was like all the knowledge. And when I was acutely ill and I was in the ER, it was like all the knowledge that I had flew out the window and
Mm.
I became a patient. And I think it resonated with me. You know, you want to treat people that you so I when I have sick patients, I think of that time when I myself was a patient, because it did something to the way I treat people.
Mm.
And I think unless you have been a patient,
Mm.
sometimes maybe more physicians sometimes need to be patients, because then it brings a second level of empathy
Mm. That
where it
bedside courtesy, that bedside,
yes, yes,
that,
where you learn to
that
treat
patient,
people.
that
Yes,
patient love that when you go see a doctor, you don't feel like you're just a number. That
exactly,
time is just,
exactly,
I call it my 15 minutes of fame when I'm in the grocery store. Hold up, this is my 15
exactly.
minutes of fame. So when you go
Yeah.
see a doctor, you don't want to feel like you're going in and out. You just like
You're just a
next,
number.
next,
Exactly. Next,
next.
next.
Yeah.
Exactly. So I try to, and I've asked the Lord to help me,
Mm.
always remember. And I try never to forget when I was that patient, because I had to depend on somebody else. And that's
Mm.
what patients, when they come to us, they're depending on us to advocate for them, to do the best for them, um, to help them be healthier. So I take that very seriously. I take that charge very seriously, and I try to live that in my everyday life.
Mm. Thank you, Dr.
I take
Lilo.
care of my patients. So
Thank
for
you
me,
for
it's medicine really has been a calling for me. It has been. I can speak for myself. It has been a calling.
and I'm sure when someone specializes in a particular field, if they're serious about it, that they will mature in it.
Right.
I'm sure that starting out when you were younger to where you at in your age now, you have matured, and that empathy
Absolutely.
and that compassion comes more. Yes.
Absolutely. Absolutely.
What is
Absolutely.
what is your favorite scripture, phrase, or testimony that keeps you grounded?
Well, I have several, but one that comes to mind is Jeremiah 29:11. I know a lot of people love that scripture. It says, "For I know the thoughts that I think toward you,"
Mm,
said the Lord, "thoughts of peace and not of evil, to give you an expected end." And when I
mm,
look at the journey that I have been through, a small island girl, never knew exactly how I would come to, you know, get to medical school, to go through that. I mean, it's been a journey, and I've been through a lot of things to get here.
mm.
It's not been easy, and that's why, when we see others, we don't know exactly how they have made that journey to get to where they are. But, I know through my faith, and I know that through God's grace, He has kept me, and that's how I have come to this point in my life.
A local
So
pastor, a local pastor frequently says, "They see my glory, but they don't know how I got here." Oh my God. I love
that
that
is
phrase.
true. That is so true.
know.
That
So
is
they
so
might
true.
see you in your space now being happy and the things you have accumulated and the way you look, but they don't know how you started out to get there. You
That's
know,
right. That is
Woo.
that is exactly correct.
Yes,
Exactly
yes,
correct. Yes.
yes.
And you know
My
what? And even though it may seem like I may have arrived, we constantly go through things. We constantly go through things in our personal lives. Um, and because medicine is what we do. It's not necessarily who we are.
right.
We're still regular people, and we go
Yes,
through things in our lives.
yes. I sit
So
here
we
and
have to
ask
persevere.
I sit here and ask people conversations about what they give to the community or to their business or to their
Right.
nonprofit or their
Hmm.
organization. But we still have another life that we have to deal with off camera,
Absolutely.
off social,
Absolutely. Absolutely.
especially.
Absolutely.
Especially. What is your wisdom or advice? I have a two parts. You gave me another thought when we were coming to the conclusion. What is your
Okay.
what is your wisdom and advice for people to avoid getting CKD? And what is your wisdom or advice for people living with CKD?
Okay, so let's talk about avoiding chronic kidney disease. Um, I'm just going to reiterate kind of the things I said before. So, if you don't have high blood pressure, you want to things that you can do. I think stress. Try to minimize stress in our lives, because stress affects us in so many different ways. We have elevated blood pressures from stress. Sometimes we overeat when we're stressed. When we overeat, then we gain weight. Cortisol levels rise. We gain weight. We become obese. And, those are things, just learning to take one day at a time. We live very stressful lives. We're in a hectic society. There's so many demands on us from family, from jobs. You just have to learn to just take one day at a time. I would say, um, learn to take time, just be peaceful, be able to reflect, to meditate, just be quiet. And, I personally find my relationship with the Lord to be extremely important. So that higher power, I think that having a relationship is important. Having a relationship with a higher power other than yourself, because we are not the end. We're not it. So, just those are things, just to be able to just to get yourself in a position where you can live healthily. That's the way I think, probably, to avoid chronic kidney disease. Avoid certain medicines. Excess of anything is not good. Excessive anti-inflammatories, pain medicines. The less stuff you put into your body, the probably the better. Um, using some natural remedies, maybe for inflammation, some turmeric, some, just bromelain, just finding some natural things sometimes instead of the man-made synthetic drugs. Um, those are might be some of the ways. If you're, we try to avoid diabetes by not being overweight, by eating healthily, less sodas, less sugary foods, um, eating more naturally, eating fresh foods. I know some people live in food deserts. They don't have a greengrocer right around the corner that they can just run and pick up fresh fruits and vegetables. But actually, in southern Georgia, we're kind of blessed because usually you'll find somebody on a corner selling some fresh produce. Really, I mean, yeah. So
Yes.
we're not truthfully in a food desert. We don't have to go 50 miles to find something fresh to eat. You know,
Mhm.
so we're blessed in that way here. But there's some places where there are true food deserts where people have to either eat just canned goods, they're not fresh fruits and vegetables readily at hand. Um, but if you can't, you try to eat as healthily as you can. Now, if you're living with chronic kidney disease, you want to do similar things. Restrict your sodium, just cut back on salt. Um, you want to limit phosphorus in your diet. Phosphorus are in a lot of the foods that are processed. So when you go shopping to the grocery store, you want to eat, try to get foods from the periphery, the outside of the grocery store, where you have your fruits and vegetables on the outside, the fresh stuff. On the inside of the grocery store are the processed, the packaged stuff that have to be frozen and and additives added, phosphates added to give shelf life. Those things aren't so good. So you want to kind of avoid as much phosphates as possible. Try to do more fresh vegetables, fresh fruit. That is better. Um, so we talked about, don't eat so much protein. There's some people who like a big old steak for breakfast, a big old steak for lunch. Try to minimize the meat, because if you're already spilling protein and then you're eating excessive amounts of protein, that's not good. It will cause damage to the kidneys and tax the kidneys and make them work harder. So,
Mhm.
those are some basic things to do. And then just reduce stress in your life. It's hard. It's easy to say, it's hard. I know it's harder to do, but we can do it. Just try to live simply. I have to remind myself of that daily. Just live more simply. Just try not to be bothered by, we have so many demands on us daily to do this, to do that. If the less we can, live a hectic lifestyle,
Mm.
be totally encumbered by worries, and just try to live more simply, I think the better for us all.
Mm. Mm. Dr. Collette Lee Lewis, thank you for your time. Thank you
You're
for your
welcome.
knowledge. Thank you
Thank
for
you.
your wisdom. And
Thank you.
anytime that there's any medical updates or kidney
Okay.
month comes again, you are welcome to invitation to a conversation anytime. And if you know
Thank you.
anybody else in another health field that
Sure.
they know that is a common um, thing that everyday people are working with, like hypertension, heart trouble, have them give them my number or give them
Okay.
share them with me.
I
And
surely, you surely won't have a problem because I already can think of a couple. And of course, this conversation was quite appropriate because March is National Kidney Month. So,
okay,
talking about chronic kidney disease in March is just so appropriate. And then, we need to just keep this dialogue and conversation going all year long, because it's not just a problem in March, it's a problem all year long. It's a problem that is very serious, and it's a problem that is rapidly growing. But with education and programs like this, we can definitely make a change.
yes. And so when you say that, since we already introduced you to the invitation to the conversation community, we don't have to do that in depth or your background. You'll
No,
just come back on as
that's right. And we can chat.
as a continued guest. And
Absolutely.
right now I'm looking for somebody out of Social Security to discuss people turning 62 and 65 about Medicare and Medicaid. And I'm also looking for someone to discuss 62 and 60 years old, the benefits that we can get once we turn 62 or 65,
Okay.
you know.
Okay.
So
So I'll do some thinking and maybe talk to someone and see if we can come up with someone for you. Because I mean, yeah, these are things and questions that people have that need to be addressed. And you need, you know what? I want you, once this is done, and once you have done this program, to let me have a copy, and I'm going to put it on my Facebook page because I think, you know, other people need to hear this conversation. This is such a good conversation, and we need to get you some more exposure so people know that you're doing this, because this is excellent, excellent.
thank you, thank you,
You're doing the Lord's work.
thank you, thank you. Yes, yeah, it was him who drove me to this. It was him who gave
Yes,
me the spirit to
yes,
do.
yes.
Okay, Dr. Lewis, we're gonna have to talk after we off camera. We ended and see all those questions wasn't as long as you thought. We
I
did this.
see, I see. Yes.
You take care and have a blessed Sunday.
Thank you, darling.